Sherlock Holmes' favorite dialogue is this: you see, but you do not observe. So when we deal with sick kids or relatively sick kids who are brought in to the emergency room or to your clinic, take a bit of time to kind of, as you are starting the necessary immediate intervention, take a little bit of time and observe the child, observe what is the pathophysiology that is deranged in the child. So this is called critical thinking or thinking on one's feet. So as you're kind of analyzing and seeing, okay, this child is sick, now this child has an airway or breathing involvement, the possible diagnosis is a bronchial asthma or foreign body. As you're thinking that way, you will automatically have a plan of action in your mind. So please remember, in sick kids, for that matter, for anybody who is unwell, you need to have a reason, you need to have an answer to the pathophysiologic abnormality. If you don't have a reason, you will not be able to treat that abnormality. So please do not just see, please observe and assimilate information. The pediatric airway is completely different from the adult airway. Children are not little adults. So what are the salient differentiating features? They have a large occiput and a relatively large tongue, especially in infants. So children who are less than a year or sometimes a year and a half or two, when you place them on the supine position, as is the case in sick children, what happens is, because of the large occiput, the neck automatically flexes, and the tongue also kind of is slightly larger. So the neck is flexed and the tongue, in a child who is semi-conscious or unconscious, the tongue falls backwards. And this causes an apparent airway obstruction in a child who may not have any kind of an anatomic airway obstruction. So this tells us that we need to probably place a small shoulder roll, a towel which is rolled and put under the shoulder, not under the neck, under the shoulder, to kind of slightly lift that airway. That is called the head tilt and chin lift maneuver. So we'll be talking about that in detail in a bit. So the second point is the larynx is probably more anterior and cephalad, which not in all cases, but probably in some children, some infants, it can be more anterior, which means that this will determine the kind of laryngoscope that you may use. This may determine whether you will give a good shoulder thrust or you will actually flex the neck to intubate. So this also we will be talking about when we deal with intubation. So please remember that the larynx can be anterior, and this anatomy has to be kept in mind while inserting a definitive airway like intubation. The epiglottis is narrow and long and is floppy. So most of the time what happens, this again helps us to kind of change our maneuvers while intubating, because of the floppy epiglottis keeps on falling into our visual field when we are trying to intubate. So you need to kind of devise techniques where you will kind of lift that epiglottis quite upwards so that the cords come into view when you intubate. So remember that this is also the case in children. The epiglottis is long and narrow and is floppy. The tracheal diameter is narrow and the distance between the tracheal rings is also shorter. So a child with any kind of an upper airway obstruction, be it an anatomic obstruction or a physiologic obstruction, especially in young kids below 2 years, below 5 years. So this, like we know, the resistance is inversely proportional to the fourth power of the radius. So if there is an anatomic or a physiologic obstruction, the resistance seems to be much more affected than when compared to an adult where the tracheal diameter is kind of wider. So children are prone for airway obstruction much more easily when compared to adults. The tracheal length is shorter. So again, for intubation, like when we are intubating, when we have actually put in the tube into the trachea, sometimes the junior doctors are so kind of happy that they just keep pushing it in, pushing it in, pushing it in. So please remember to intubate the right bronchus is very, very easy in a child because of the shorter tracheal length. And like I told you, the smaller airways are also narrow, but the larger airways are even narrower. So children with asthma, children with bronchiolitis, they tend to come with severe distress just because the larger airways are also narrow in kids. So these are the anatomic salient features in children that make them more susceptible to develop any kind of airway obstruction, even though it is mild. breathing mechanics. So we spoke about A, which is airway, and now breathing mechanics are also kind of quite different in children. So if you see an adult who comes with respiratory distress or pneumonia, he may kind of hold on for a couple of days, whereas a child with a pneumonia, even if a small portion of the lung, only the upper lobe is involved, these kids kind of they become disproportionately more tachypnic, and their work of breathing is disproportionately higher. It's because of multiple factors, apart from the fact that their basal metabolic rate is increased. In small children, like I told you, the resistance to breathing is higher because of the narrower airway, the larger and the smaller airways. Control of breathing, the central control which comes from the brainstem, is also immature in young kids, especially infants. So the breathing mechanics kind of go a little haywire when they have been tachypnic for a while. The lung volume is obviously lower when compared to adults. The efficiency and the endurance of the respiratory muscles, here I'm talking about the diaphragm, the intercostal muscles, the subcostal muscles, the sternocleidomastoid. So these muscles, which all aid as accessory muscles, their efficiency and endurance is also less. So this is why a child, especially a young child who is less than about 3 to 5 years old, becomes more susceptible, or rather goes into respiratory fatigue and failure much more easily when compared to adults. So the mechanics have to be thought of also in children with involvement of the airway or the parenchyma. The need to recognize respiratory distress early in children is related to their anatomic features, like I told you, as well as their breathing mechanics, which may be altered. Like I told you class before, hypoxia and hypotension account for more than 90% of cases of cardiac arrests in children. So it is very, very important to recognize that the child is sick and is having some kind of respiratory pathology. The differentiation between respiratory distress and failure is important, but there's a very, very thin line separating the two. And we do not need an arterial blood gas when a child presents to us sick to declare that the child has type 1 respiratory failure, type 2 respiratory failure. It is absolutely not needed.